Good morning. Welcome to Module 5, that is zygomatico-maxillary complex fractures. Now, what is zygomatico-maxillary complex fracture? It refers to the skeleton unit that is formed by zygomatic bone and maxilla. This zygoma articulates with four bones, basically superiorly with the frontal, medially with maxilla, and laterally with the temporal bone, and posteriorly with the sphenoid bone through five processes. What are the various five processes? Namely, zygomatico-temporal, zygomatico-maxillary, infraorbital, zygomatico-frontozygomatic, and spinozygomatic sutures area. Because of its complex articulations, various names are applied to these zygomatic fractures. That it can be called as a tripod fractures, tetrapod fractures, or pentapod fractures. We can see the various fracture patterns in zygomatico-maxillary complex fractures. How will you classify this zygomatico-maxillary fracture? That is a Rowe and Williams. Most commonly accepted classification is a Rowe and Williams classification given in 1968. That is the first is the type 1 is a no significant displacement of zygoma fracture is seen. Type 2 is a fracture of the zygomatic arch is seen. Fracture 3, whenever there is a vertical rotation around the vertical axis of zygomatic bone. Type 4, when there is a rotation around the longitudinal axis. Type 5 is the displacement of the complex end block, that is a whole block of the zygomatico-maxillary complex that is displaced. Type 6 is the displacement of orbitoantral partition. Then type 7 is the displacement of orbital rim segment. And type 8 is the complex comminuted fractures. See, we can see the various classification of fracture in these pictures. Now, what can be the sign and symptoms of zygomatico-maxillary complex fracture? We can have sign and symptoms according to cosmetic defects or functional deficits. According to cosmetic deficits, we can have, first of all, we can have facial asymmetry due to periorbital edema, then hematoma, emphysema, then facial asymmetry due to malposition zygoma, that is a depression of zygomatic bone or malar prominence. Then transverse facial widening can be there. Then changes in the anterior-posterior projection can be there. And we can have orbital dystopia. Discoloration is basically because of subconjunctival hemorrhage or periorbital ecchymosis or edema. There can be altered morphology or position of the eye. That is the antimongoloid slant or increased scleral show can be there. Hypoglobus or hyperglobus position can be there. Or we can have inward displacement of the orbit, that is the anophthalmos, or outward displacement of the orbit is there, that is the exophthalmos can be there. Or according to functional deficit, we can have vision loss, vision problem with the vision, that is diplopia can be there, that is a double vision, with patient can have double vision. Or loss of vision can be there, that can be partial or temporary, partial or total depending on the type of fracture. Restricted mouth opening is there, then malocclusion can be there, neurological deficit at fracture line passes through the various sutures, that is the infraorbital foramen area, then we can have infraorbital nerve paresthesia can be there, or we can have zygomaticofacial or zygomaticotemporal nerve paresthesia can be there. Or if fracture line there can be some displacement or some trauma near to the facial nerve area, the patient can have facial nerve palsy. Or epistaxis can be there, bleeding from the nose, or nasal congestion can be there because of the collection of blood in the maxillary sinus. Or compartmental syndromes can occur in these patients, that is superior orbital fissure syndrome or orbital apex syndrome can occur. See, we can see in this picture there is circumorbital ecchymosis, subconjunctival hemorrhage, and depression of the zygomatic bone can be seen. Now, what are the general principles of treatment of zygoma fracture? There can be no treatment required, then indirect reduction with no fixation or with temporary support, then we can directly fix it or indirect fixation can be done. Type 3 is a direct reduction and fixation of the fractures. No treatment is required in those cases with a minimal degree of displacement following the union, unlikely to result in any cosmetic deformity. No disturbance of vision is there. No evidence of persistent paresthesia or impairment of mandibular movement is there. So no treatment will be required. Only conservative management is required in these cases. Indirect reduction. See, indirect reduction is a area where we are not directly visualizing the fracture site and we are indirectly reducing the fracture. No fixation is done in these cases. It includes procedures which do not involve the exposure of the fracture sites. Principle is to disimpact and reduce the fracture by direct application of an instrument through an indirect approach removed from the fracture line. No fixation technique which has been developed for this operative procedure are based upon introduction of an instrument through temporal fossa or buccal sulcus approach, that is the intraoral approach, or through cheek, that is a percutaneous approach, through the nose, that is the transantral approach, through eyebrow, that is the lateral eyebrow approach. No fixation, that is a temporal fossa approach. This method is introduced by Gillies et al. For elevation of zygomatic arch. Incision about 2.5 cm long, made above and parallel to the anterior branch of the temporal artery. This is the Gillies temporal approach. This is the use of the rose pattern zygomatic elevator. This arrow indicates the upward and outward force applied for the lifting of the zygomatic bone fracture. Now, no fixation approach is the lateral brow approach, that is Dingman and Nedwick approach. Advantage of this approach is that the fracture at the orbital rim is visualized directly and frontozygomatic area of the lateral orbital rim is exposed by eyebrow incision. That is the lateral eyebrow incision is given. Instrument is inserted to lift the zygoma anteriorly, laterally and superiorly. See, we can see this is the lateral eyebrow approach. We can directly reduce the fracture but no fixation is done in these cases. Upper sulcus approach, that is a Keen's approach. Access is gained by incision about 1 cm in length at the upper buccal sulcus immediately behind the zygomatic buttress. This is the intraoral approach, that is for the reduction of the zygoma fractures. We can use the percutaneous hook approach, that is Possvillo pattern, for the reduction of the zygoma fracture. Intranasal transantral approach we can use, not common in use. That is how we can do it. An opening is made into the antrum below the inferior meatus and a curved urethral sound introduced and manipulated so that it tips lies on the antral aspect of the zygomatic bone. Firm outward and upward pressure is applied to reposition the fractured zygomatic bone. Direct fixation, transosseous wiring or osteosynthesis, separation at the frontozygomatic suture line with displacement in excess of 2 to 3 mm is likely to cause detachment of periosteal or facial attachment. So, direct fixation becomes necessary. Gillies temporal approach is preferable if there is separation at the suture, or percutaneous repositioning may be preferred. Access to temporal axis of the zygomatic bone can be obtained through frontozygomatic incision by passing a curved elevator supraperiosteally posterior to frontal process of the zygomatic bone. See, these are the various photos showing the Gillies temporal approach. We are giving the incision, skin incision at the temporal region and various layers are exposed. The whitish layer we can see is the temporal fascia. Then below the temporal fascia, muscle is there. Between the muscle and muscle, we will move our elevator and elevate the zygomatic bone. Elevation of zygomatic bone and transosseous wiring or bone plating for frontozygomatic suture may achieve a stable realignment of the orbital ring. Or if there is more severe displacement or dislocation of zygomatic complex and block fracture is there, it will lead to separation of fracture ends at the inferior orbital margin with fracture passing into the orbital floor. In this type of fracture, unstable fracture is there. So it is essential to carry out osteosynthesis, transosseous wiring or plating technique. Application of small plates across the frontozygomatic suture will usually ensure there is absolute immobility so that union can take place. Precise alignment of inferior orbital rim is essential after reduction. So, what are the advantages of maxillary vestibular approach? Access to entire facial skeleton of the midfacial region. It is safer. Hidden intraoral scar is there. Quick and having few complications. There are various areas where we can place the plates, that is the frontozygomatic suture, intraorbital rim and zygomatic buttress area. There are concepts for the 2-point or 3-point fixation. 2-point is the area required in the simple or non-comminuted zygomatic or maxillary complex fracture, or site of fixation, that is a frontozygomatic suture, infraorbital rim or maxillary buttress. 3-point fixation, non-comminuted zygomatic or maxillary complex fracture, sites of fixation, abscess suture, infraorbital rim, zygomatic arch or maxillary buttress. We conclude with the zygomaticomaxillary fracture. It is one of the most common, most complex complex fracture to reduce and fix because of its propensity to undergo displacements in all the three planes of orientation along its five articulations. Accurate reduction is challenging due to difficulty in intraoperative assessment of reduction, inability to predict the rotation of zygoma during reduction, and complexity involved in the concomitant orbital fractures. Thank you.